Dr. Diana,
Yeah,
can you hear our voice?
okay.
Can we start this event, Dr. Diana?
Yeah, please.
Okay. Dr. Novita.
Halo, Assalamualaikum. Selamat pagi, Dr.
Waalaikumsalam.
Alzamani.
Waalaikumsalam. Selamat pagi juga. Pleasure to be back.
Okay, can we start our event, Dr. Novita?
Ya.
Okay. Dr. Alzamani, we can start our event tonight. This morning.
Ya.
Nah.
Jadi saya teruskan mulakan.
Biar kami yang memula dulu.
Okey.
Ya. Sedikit bahasa Melayu tak apa.
Tak apa, saya ikut saja.
Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Allahumma sholli ala Muhammad wa ala ali Muhammad. First, thanks to Allah for the bless and the mercy. We can join with the healthy condition this morning to hear seminar for ultrasound. The Honorable of our teacher, Dr. Novita Anggraini, SPAN KIC MCAS, as the chairman of anesthesiologist and intensive therapy program of Arifin FCC as a moderator for this event for this morning. And then the Honorable of Datuk Dr. Alzamani Mohammad Idrose as a speaker for this morning. May Allah bless you and always healthy. Assalamualaikum, Dr. Alzamani. How are you today?
Waalaikumsalam. I'm feeling good and thank you for your doa. I pray the same untuk anda semuanya di sana. Looking forward untuk share sedikit perkongsian ya dengan anda semua pagi ini.
Thank you, Doctor. Okay, the honorable to our teacher, also our mother, Dr. Nazlina Santoso, SPAN KOKP MH, and also join with our event this morning. And welcome to all of the participants of this event. I am Dr. Zita Rahmat as the resident of anesthesiology and therapy intensive in Arifin Ahmad Hospital as the master ceremony for this event. We excited to hear and focus to our lesson this morning about how to do basic ultrasound made easy. So we can hear and also focus for Dr. Alzamani presentation of this morning. Okay, next we can invite to Dr. Novita Anggraini, SPAN KIC MCAS, to open this event. Please welcome Dr. Novita Anggraini, SPAN KIC MCAS.
Assalamualaikum warahmatullahi wabarakatuh. Maaf, mungkin sedikit ribut. Saya masih di perjalanan dari Bandung kembali ke Pekanbaru. Selamat pagi, Dr. Alzamani, Dr. Diana, Dr. Nazlina, dan teman-teman semua. Alhamdulillah kita masih diberi kesehatan, diberi umur untuk kembali bertemu di dalam forum residen anestesia Universitas Riau, anestesia. Semoga tetap konsisten setiap bulan kita upayakan untuk selalu share pengetahuan, informasi kita memberikan juga untuk yang lain. Mudah-mudahan ini amat sangat bermanfaat buat kita semua. Terkhusus Dr. Alzamani, my best friend. Thank you for joining us again, and I hope this is not the last time. I do hope we have more and more lecture from you. Yes. I believe we already have new fans in Pekanbaru.
Insyaallah.
Ya, tidak memperpanjang, saya kembalikan ke MC Dr. Citra dan Dr. Diana untuk melanjutkan kembali. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thanks for Dr. Novita. Okay, next we invite Dr. Diana to lead the lesson for the presentation of the K22 basic ultrasound made easy. But first, we can precaution of the rule of this event. The presentation of the Dr. Alzamani, we can hear in 45 minutes, and also then we can discuss the topic in 30 minutes, ask and answer. The participant can ask the question with the chat column or raise your hand. So that's the rule of this event. Only me, the expert, had to do basic ultrasound made easy. Before this, we invite Dr. Diana as a moderator for this morning. We have pantun for open the seminar. Pagi yang cerah untuk berolahraga, berkeringat banyak tandanya sehat. Hari ini rinestesia kembali mengudara, tebar manfaat dengan ilmu yang padat. We invite Dr. Diana to lead this lesson. Dr. Diana is born in Renberg, Germany, and also now we stay in Indragiri Hilir, Tembilahan. So many experience for the Dr. Diana Maskur, MKes, SPANTI, FCC, that get fellowship critical care in Universitas Udayana Denpasar, Bali. So now they stay in Indragiri Hilir in Puri Usada Hospital since 2017 until now as a specialist anesthesia and therapy intensive, and so many experience of the organization, and now the chair of ED Cabang Indragiri Hilir in 2022 until 2025. So please welcome Dr. Diana. We can hear and focus with this event.
Okay, thank you, Dr. Citra. Assalamualaikum. Good morning, Datuk. Salam kenal dari saya.
Salam kenal kembali.
Baik, untuk mempersingkat waktu kita mulai saja langsung, ladies and gentlemen. Thank you very much for preparing yourself to join our virtual conference. Seperti seperti MC, kita akan sebagai rumpun Melayu, satu rumpun ya, Datuk. Rumpun Melayu yang suka berpantun. Saya juga ada pantun pagi ini, pantun pembuka. Petik sekuntum bunga pematang, bunganya kecil dimakan ngengat. Assalamualaikum, selamat datang. Saya sapa hadirin dengan hangat. Sungguh rindang pokok memplam, indah sungguh dipandang mata Pak Atan. Kepada Datuk Alzamani saya ucapkan salam sebagai tanda perkenalan dan persahabatan. Assalamualaikum warahmatullahi wabarakatuh. Good morning everyone. The Honorable all lecturers of the Riau University and the Honorable all participants of this virtual conference. Ladies and gentlemen, I am Diana, the moderator of today's panel session. I am very pleased to see you here and welcome all of you to this conference. Today's panel session is about head-to-toe basic ultrasound made easy. Ladies and gentlemen, our speaker today is Dr. Alzamani Mohammad Idrose. Assalamualaikum Datuk. Welcome. Welcome. I will read your profile, Datuk. Datuk Dr. Alzamani Mohammad Idrose is currently consultant emergency physician at Hospital Kuala Lumpur, Malaysia. At the same time, also the head of Pediatric Emergency Department of Hospital Tunku Azizah Kuala Lumpur. CV Datuk ini banyak sekali ya. Yang tentunya sangat inspiratif, namun karena keterbatasan waktu izinkan saya untuk membacakan sebagian saja yang terupdate ya Datuk. Kualifikasi Datuk Alzamani ini sebagai PhD in Sport Science and Recreation from UITM in 2020, kemudian Fellowship of Emergency Medicine Critical Care Program in 2021. Areas of interest Datuk itu disaster medicine, ada critical care ultrasound, kemudian beliau critical care in emergency medicine, kemudian medical legal management, high altitude emergency. Research activities Datuk it presented a total of 161 science paper in local and international conference, 226 publication in abstract paper proceedings and non-journal articles, 31 full paper publication in journal and book chapter. Peran dalam masyarakat Datuk Alzamani ini merupakan kolase dokter gawat darurat presiden terpilih Malaysia, kemudian pernah mewakili Malaysia untuk Komite Medis International Climbing and Federasi Pendakian Gunung Swiss. Kemudian beliau pendiri Asosiasi Resusitasi Malaysia, MyRes, MYRES, anggota Twitter Medis Malaysia, MedTweetMy, anggota Seumur Hidup Asosiasi Medis Malaysia, kemudian relawan dengan Mercy Malaysia untuk misi kemanusiaan. Datuk Alzamani ini juga penerima award dan prize, antara lain dia pernah won more than 20 prizes for paper presentation locally and internationally. Beliau juga pernah national champion of 3 minutes thesis competition in the category of science and technology in 2018. Kemudian best continuous medical education presented for 3 consecutive years at HKL. Award Pingat Setia Diraja Award, carrying the title Datuk at the federal level by His Majesty the 14th Agung of Malaysia in 2016. Yang paling menarik adalah personality dan karakter dari Datuk Alzamani. Jadi selain sebagai profesional, Datuk Alzamani ternyata mempunyai jiwa seni yang tinggi ya Datuk. Datuk Alzamani adalah seorang penggiat integritas dan kemanusiaan dan konsisten menulis artikel tentang nilai integritas dan kemanusiaan di koran lokal dan majalah internasional. Datuk juga seorang penyair yang produktif dan melakukan upaya serius dalam pengobatan memanusiakan, kemudian mengkoordinasi malam puisi kemanusiaan sebagai malam penyembuhan bencana. Sebagai tokoh berpengaruh di media sosial juga dan menggunakan bidang ini untuk pengobatan darurat. Datuk percaya pada kerjasama tim dengan kerendahan hati di tengah kepercayaan, berpegang pada prinsip bahwa kepala boleh berada di langit tertinggi, tetapi kaki harus kokoh di tanah. Ini patut kita apresiasikan sangat tinggi dalam kehidupan sehari-hari kita. Demikian CV dari Datuk yang begitu panjang ya Datuk ya, banyak pengalaman Datuk. Kemudian kita akan memulai season kita, rule of session-nya. Datuk Dr. Alzamani Mohammad Idrose, you have 30 minutes to present your paper. And for your information, our audience are faculties, researchers, and students also. Before the presentation begins, let me inform how the presentation we will be going on. First is the presentation of the material. Second is the question and answer session. At least is conclusion. Now, allow me to welcome the speaker, Datuk Dr. Alzamani Mohammad Idrose, to deliver the presentation. Datuk, time is yours.
Thank you. Saya balas pantunnya ya. Di Pekanbaru makan rambutan dengan permisi. Terima kasih atas jemputan. Saya gembira untuk berkongsi. Jadi saya teruskan dengan perkongsian saya. Saya rasa sebenarnya presentation ini lebih sesuai untuk 1 jam kerana ia adalah ultrasound dari kepala ke hujung kaki ya. Sebentar, saya cuba berkongsi. Jika ini berjaya, boleh dilihat skrin saya?
Bisa, boleh dok, Datuk.
Okey, saya teruskan saja. Saya cuba secepat mungkin. Tapi it's an impossible task because usually when you learn ultrasound, it is a workshop that takes a few days. But this is something I'm attempting to do in 1 hour and trying to simplify it. I have the video that simplifies everything, but if the time it's taking too much time, then I will just show you the principles of it. But anyway, we'll move on. Yeah. So basically what I'm looking at for a head-to-toe ultrasound is as in regards to resuscitative ultrasound, and I see we have 88 participants in this talk today. And when we do resuscitative ultrasound, actually it does involve a bit of a head to toe. And when we approach patient, it's always we approach it in terms of the patient who arrive, especially in my context, because I'm an emergency specialist doctor, that when they come, we always deal in terms of the ABCDE. That the airway is all right, the breathing is all right, the circulation is all right, the disability is all right, and then in terms of the exposure in terms of other things. So when we're looking at the airway, we're looking at the, for example, which is relevant in resuscitation in terms of the location, in terms of the cricothyroid membrane location that may be problematic in some patients that we could use the ultrasound to locate. We can use the ultrasound in terms of the breathing, whereby we can assess the lungs, that whether there is pneumothorax, for example, whether there are fluids, pleural effusions, or pneumonia. And this is especially useful during the COVID-19 when we using the probe to categorize the patient, the COVID-19 patient. Because we can look signs of pneumonia with the lung ultrasound. And in terms of circulation, we could do the echocardiogram. We can look at the heart and to look whether it's contracting well, whether there's a pericardial effusion or cardiac tamponade. So we can do that. Or someone having myocardial infarct, we could also take a look at that. along the under circulation, also we can use the ultrasound, for cannulation, the granula and whatnot. We can also look whether there's any signs of intra-abdominal bleeding, especially in trauma, by doing focused abdominal sonography in trauma, focus assessment with sonography in trauma, fast ultrasound, whereby if we look, we can detect free fluid. It indicates intra-abdominal injury, especially in trauma. And also, we can look at for circulation also for large hematomas. For disability, this is about assessing the neurology, whereby we could actually look at the pupils. In fact, we can look at whether there is a midline shift of the brain using the ultrasound. And in terms of exposure, we can look whether, for example, foreign body, we can use the ultrasound. So I'm going to try and share with you in terms of airway, how we use the ultrasound to assess the airway. So this is a photo of someone with cancer, whereby to access the cricothyroid membrane in the event of there is the airway obstruction, you cannot find the cricothyroid membrane easily. So, but you can use the ultrasound to detect it and insert the tube, also for tracheostomy. So this is for cricothyroidotomy. That there are also situations when it is performed, there's bleeding, and in fact, there's also in doing tracheostomy without the ultrasound percutaneously, that one may hit a vessel and cause bleeding. So using the ultrasound, you can actually, when you put the probe, you could detect an artery, and you could avoid from puncturing the artery during such procedure. So this is an example. So this is what we do when we want to do ultrasound for the airway. So you can put the probe, a high frequency probe like this, which is good for superficial structures. And when you put it like this is what you get on the image with a probe position like this. So basically, you see this structure. This is on top of the neck here. This is actually the thyroid gland. This is the right gland. This is the left gland, and this is the isthmus. And you will see that immediately after this, there is like a black area that is the cartilage. And when you see this bright lining, that is actually air, and this is actually the whole thing here actually is correlating with the trachea. So and when you move the probe upwards, then you will see that from a small slit like black position like this, suddenly it becomes big. This is actually the cricoid, the cricoid cartilage. So from here, if you go further up, you could see it becomes a bit like a V shape, and this is already at the thyroid cartilage. So for us to locate, it is it is between this cricoid and the thyroid cartilage, and if you turn it into longitudinal, you will find that it will be something like this, like a dolphin jumping out of the sea, and it is actually above here. This is the thyroid, and this is actually the thyroid membrane. So this is what I was saying just now. This is the thyroid lobe, the isthmus, the tracheal cartilage. This is the tracheal wall, the bright one. And in fact, you can see the esophagus here. And if you actually intubate patient, you could actually see your tube inside the trachea. Sometimes it's intubated, it goes into the esophagus. You could also see the tube over there. Okay, so this is what I was saying just now. When you slide the probe upwards, you will see this structure. This is on the transverse view of the ultrasound. And when you turn it into a longitudinal, you will find that this structure, the cricothyroid membrane, and when you move further upwards, you will find like a V-shaped structure, and this is actually your vocal cord, yeah? The vocal cord. So you could use the ultrasound to assess all this to determine the site of your cricothyroid membrane. Yeah, for example, this is in terms of longitudinal view, and when you do this, you will get this structure, which I actually equate it to something like a train. This is kepala kereta api, dan ini gerabaknya. Dan gerabak yang pertama ini yang paling besar, dan ini kepala kereta api, dan ini adalah cricoid cartilage, ini adalah tracheal cartilages. Yeah. And kalau you move upwards ke atas, ya, daripada tracheal cartilage, ini seperti dolphin yang melompat keluar. This is the cricoid cartilage, and when you trace it upwards, this is thyroid cartilage, dan di sinilah lokasinya cricothyroid membrane. So itu adalah untuk airway. I will just try to show you a video.
This is the ultrasound of the airway, and we use a high-frequency transducer to scan the patient. We just put the probe first in this transverse manner, and when you put the probe on the front part of the neck, you could see this thyroid. So this is the right lobe, this is the isthmus, and this is the left thyroid lobe. And if you look here, the bright part is actually the wall of the trachea. So this is your trachea. Now I move this probe upwards. As I move upwards, you can see here this wall, the bright wall, up, 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 and suddenly it becomes big. This whole big segment is your cricoid. So if I move further up here, you can see from this like a C segment, which is your cricoid, it forms a strip like this, which is your cricothyroid membrane. If I move upwards some more, then you will actually see this is the part where this is the vocal cord, and if it says R, it moves. Yeah. Okay. Now this is on transverse view. Now I'm going to change the probe to longitudinal view like that. So in this view, when you look at the, just try to make it bigger, you are looking for a set of train. You look at this, there's a locomotive with the, the train. The largest, the longest one is your tracheal ring 1, and subsequently tracheal ring 2, 3, 4, 5. So if you look here, after the tracheal ring 1, there's like a dolphin jumping out of the water, this shape. And that is actually your cricoid cartilage. Now I move forward, upwards, and as I move upwards, you can see here, it forms like a small strip here to this cartilage actually, which is actually your thyroid cartilage. In this strip is actually your cricothyroid membrane.
Oh. Okay, so now we move on to breathe for breathing. When we assess the breathing, we're looking at the lungs. Yep. So we put our probe like this, and it is in longitudinal manner. You know, there are ribs across. And when we look at the lungs, this is a normal lung. You will find that there is the movement up and down, which is the sliding sign. Yeah, it moves up and down, that little ends moving up and down. That means that there is a movement of the breathing, the lungs. So this is when we snapshot it. This is actually the first part is your pleura, and you'll see multiple longitudinal lines, which are actually just the reflection from the sound wave. These are actually artificial, but this means this is a normal lung. And when you look here, there's a like a black appearance here on both sides that makes it appear like a bat. So this is a normal lung with multiple longitudinal lines, and this is what we call the A lines. So this black part is actually the rib shadow. This is the in between the ribs, and this is another shadow. Yeah. So for someone who has a wet lung, for example, in pulmonary edema or fluid overload, you will find multiple vertical lines like this. Just now it was longitudinal, it was a dry lung, dry normal lung, but this one is actually a wet lung. So the ultrasound can help us differentiate between dry or wet lung to narrow down our diagnosis. Now with the ultrasound probe, also we can look at pleural fluids, a collection of fluids, which is, if you look here, this is actually the liver. This bright part is actually the diaphragm, and above the diaphragm you see a black collection here, or hypoechoic. This reflects a pleural effusion. Yeah. We could also use the ultrasound to look for pneumothorax. Yeah. And for pneumothorax, what we see, remember the bat sign just now, the black, and then this is the longitudinal A lines. So usually in pneumothorax it appears like this, dry, but you will find there's no movement of the what we call the sliding sign going up and down of a normal lung that I showed you initially. And if we put an M mode over here, you will find that it appears like a barcode sign or a stratosphere sign, whereby it's straight line all the way. So this is an example of pneumothorax. Yeah. In a normal lung, it appears like this. I always say that it looks like, if you are looking at painting of the sea, you'll find that this is the sea straight, and this is the beach, pantainya, ya, pasirnya. And this on M mode is the feature of a normal lung tissue, a normal working lung. But in a patient that has pneumothorax, you will find that this the pasirnya ataupun kawasan pasirnya sudah menjadi seperti pantai, seperti straight line all the way. So it's like seumpama tsunami datang, ya, and all the way, and this is not good. This is the example of pneumothorax finding. Yeah. So this is what you can find on lung ultrasound. Yeah. So this is when you look at the ultrasound, the lung sliding that I said just now, the movement up and down when you put the probe. This one, if it is present, it rules out pneumothorax. But if you do not have that, and then there is loss of lung sliding, there's also other things that can cause this loss of lung sliding, like pleurodesis, atelectasis, collapsed lung, pulmonary fibrosis, massive consolidation, and also if there is no ventilation or patient stopping breathing, you will also get loss of lung sliding. So this one I mentioned just now, dry versus wet lung, whereby we call it the A pattern versus B pattern. The A pattern is like the normal lung, whereby you see that there is longitudinal line only. But here, for B pattern, a wet lung, you find that multiple vertical bright lines, and this could be anything: fluids, acute pulmonary edema, end-stage renal failure with fluid overload, congestive cardiac failure, ARDS, and pneumonia can present like that. So yep, so this is a A line, a dry lung, yeah, appears like this, and this is the B line that appears vertically like this. I think I mentioned this just now to you. Yeah? So B line, this is a wet lung. So beeline is like this reflection. When I was walking by the lake, you will see straight like this. That signifies a wet lung. Yeah. So this is an example of acute pulmonary edema. This is the lung ultrasound with multiple straight lines like this. So this correlation, it correlates also with the failure. With the more lines, it's a patient is having a worse cardiac failure, for example. So we use these B lines to differentiate between dry and wet lung, so that we know if someone having shortness of breath, whether this is a problem of, for example, COPD, pneumothorax, which have A line feature, versus someone that has a B line feature on lung ultrasound, which signifies a wet lung, and it could be pulmonary edema or stuff like that. So this is, for example, cardiogenic pulmonary edema, wet lung. So for pneumonia and consolidation, you will see that they have like tissue-like pattern. It looks like a liver, and it has irregular deep border and what we call a bronchogram. So if you look here, this is the liver. This is actually the lung part. And when you look here, it looks like very much like the liver. This part. It's not supposed to be like this. It's supposed to be like an A-line feature, but it has this. The bright marks are air bronchograms, actually, this part. Air is actually bright on ultrasound. So this is the diaphragm, the liver, the kidney, but this is actually a consolidation for someone having pneumonia. So this is an example of how you do lung ultrasound.
For lung ultrasound, we can use either abdominal probe, whereby we can see a deeper structure, or if you really want to concentrate on the superficial structure, you can also use the high frequency probe. So for this, I will use an abdominal probe. So for lung ultrasound, you could divide it to right and left, and you can scan the area from here, for example, here, it is called R1, R2, R3, and R4. And some people will scan behind, it will be R5 and R6. So R for right. And if you scan on the left side, it will be L1, L2, L3, L4, and L5 and L6 if you scan behind. So I will show you when we scan the R1 area first. So what you do is that you place your probe. If your reed is like this, you place it like that. So here, and immediately you can see here, there is a shadow here. This is the ribs. This is the ribs. Actually, this is called a bat sign, like a bat. You can see the wings here. So this is the ribs. And if you focus here between the ribs, let me make it bigger by reducing the depth and reducing the gain. You could really see the movement of the pleura. This is your pleura. And as he breathes in and out, you can see it moves up and down. And this is called sliding sign. And that is normal. You could put on air mode, cut it through, and you could appreciate the appearance. Breathe in and out. Yeah, you can. Okay. So when you look here, this straight line is like the sea, and here is like the sand on the beach or the shore. So this is normal, and we call it seashore sign. But if there is no ventilation, or in pneumothorax, you will see that this part is not become like sand, it will become like sea, straight. For example, I put it back, my throat back, and then now I will ask him to stop breathing. Just stop breathing for a while. You can see that it has become straight. Now it has become sea. The beach is like, it has become sea. It's like sea. It's like a tsunami, and that's bad. So this is called a stratosphere sign, or some people call it a barcode sign, which means there is no ventilation on the lungs, or in pneumothorax, you will see this pattern. Now, you will repeat the same examination with the probe at R1, R2, R3, and you place it a bit, actually the ribs is like that over here, so it will be like that. So always place it above the ribs like that. So the ribs is like that over here, that's why you put there, that would be at your R3. And then here at the R4, just like when you do ultrasound, when you do fast, you put a bit more gel, okay, here, and let me increase the depth, increase the gain. Okay. Now you could see your liver here when you, just like when you're doing fast, right? But now you're concentrating this area, because this is your diaphragm, the bright one is your diaphragm. Okay, and he breathes in and out. And if I freeze it, this area will be really black when there is pleural effusion. And also if there is a pneumonia, for example, with consolidation, this area can appear like liver tissue. And that is called hepatization of the lungs. And this is something you can find in consolidation patients with pneumonia. So for lung ultrasound, you do R1, R2, R3, R4, and you repeat the same L1, L2, L3, L4. And that's basically what you're looking at. And sometimes when you do the ultrasound like this, if you put on M mode, you do see in pneumothorax, for example, when there is, okay, now stop breathing. What we call a lung pulse. Okay, I'm just going to ask him to breathe normally. Okay, breathe normally. Okay, breathe normally. Okay, stop breathing. Stop breathing. Stop breathing. Okay, when you see this, there is like a sandy appearance, and this is straight appearance. This point whereby it changes from sandy appearance to straight line is called lung point. And if you find that, that is one of the signs of pneumothorax. Okay.
Okay, so that's for B, for breathing. So we move on to C, for circulation. So for C, this is, we can look for under the circulation, especially, well, it can be like someone in trauma having loss of, having bleeding. So nowadays, for fast, we usually look at 4 windows. We look at the hepatorenal angle here. We look at the splenorenal angle here. 4 fluid collections, and we look here behind the bladder, in the pelvis for any fluid collection, and we also look here at the subxiphoid area for any collection of pericardial fluid. So all that can depict either intra-abdominal injury that cause bleeding inside, or cardiac tamponade over here. And if we extend it to look also for the pneumothorax and pleural effusion, that becomes what we call E-FAST, extended FAST, focus assessment with sonography in trauma. So this is very much looking for circulation problem, for bleeding problem, for cardiac tamponade problem, for pneumothorax, as well for hemothorax. So ultrasound can help us to do that. Okay, this is a fast ultrasound whereby looking at the hepatorenal angle or perihepatic scan. We're trying, when we put our probe here near the this area on the right flank, at the lower right, really at the subcostal area. So we find this structure, which is the liver, we find this kidney, and we find a clean layer here between the liver and kidney. There's nothing in between. But if there is a collection of fluid which appear black in between, that means there is a possibility of intra-abdominal injury. So that's on the right side. This is on the left side. This is a perisplenic scan between at the splenorenal angle. Again, we see the same feature on that side. We see the spleen and we see the kidney, and we see an interface between them, which is a hyperechoic line, and there's no collection in between, nothing black appearance in between. Then we look at the pelvis, and we can see the bladder here, and for male, we can see prostate, and there is nothing, a collection. Usually a collection can be in between the bladder and the prostate, black like this, but outside here. This is on transverse view. When you do it on longitudinal view, again, you can see like the behind the bladder or prostate, for any collection. For female, you're looking for collection behind the uterus. So that's at the pelvic area, and then you put your probe at the subxiphoid area, and with the arrow on that side. It doesn't matter, but when you do it, you will find this appearance of the heart, and you see that there is just a clear, nice, clean line around the heart, meaning that that's the pericardium. But when you see at this area around the heart, there's a black collection. That would mean there is a pericardial effusion, and that can be a cardiac tamponade. So this is all, as the name says, focused assessment with sonography in trauma. It stresses the patients during trauma. This is an example of an intra-abdominal injury. You see, this is the liver, this is the kidney, and you see a collection here between the liver and the kidney. That is a positive fast scan. So this is another one. This is a kidney, liver, and the collection of fluid here around the liver. That's also positive. This is in a ruptured ectopic pregnancy. You don't see, this is actually the uterus, but there is, you do not see any product of consumption inside, but you see fluid collection outside. And this is actually a ruptured ectopic pregnancy. Extended fast, just now I said, apart from the fast, looking at the hepatic, perisplenic, and pelvic area, as well as the heart, we put our probe on the chest, and we look for collection above the diaphragm. This is the liver, the diaphragm, and this means there is a pleural effusion. And we could also assess the pneumothorax the same way that I've described just now, whereby you see whether there's any loss of lung sliding, and on M mode, the loss of seashore sign, or the appearance of the stratosphere sign, as well as if you could locate a lung point, the transition between the seashore and CC. So this is an example of doing
fast ultrasound. What you need to do is use the abdominal probe with the arrow pointed towards the right and slanted like that near the subcostal area, and put your probe there and try to get the liver and the kidney just like that, and try to see whether there is anything in between them to represent free fluid. You can also see above the diaphragm here for any collection of pleural effusion. The same thing when you move on the other side near the subcostal area, but more posterior, then you try to locate the spleen and kidney. So you look for free fluid in between them, and also if there's collection above this bright area, which is the diaphragm, for pleural effusion. And then you move your probe down here, and then in a transverse manner like that, then you'll be looking at the bladder and the prostate, and if there's any collection in between the bladder and prostate. Sometimes you really see lots of fluid. And then you put your probe here, the subcostal area, and then just see if there is any collection around the heart, which can represent pericardial effusion or a tamponade. So that is fast. And when you add looking at the pleural here, as well as looking for the lung sliding, and as well as looking for the presence of a barcode sign or any lung pulse for pneumothorax. Both of that will become E first.
Okay, so that's circulation. Now, this is just a bit extension to look at, just now we look at leaking a problem under circulation, but we also look at the pump problem. Now we are assessing the heart. So when we are doing the heart, I think because of we don't have much time, but we can look at the heart contractility and if, looking for effusion, looking for cardiac tamponade. So basically, when we look at the heart, we can look at the heart from a parasternal approach, putting your probe here. We can look at the apex, subcostal, which is what we do in FAST. And another one, actually, we can look at the suprasternal approach and actually looking for the aortic arch. Anyway, when we do an echo, it's like cutting a banana. So if we put the probe, we can put the probe along the side of the banana. And then when we turn it 90 degrees, you get a short axis of the banana. And when you do a long axis, it depends where you cut it to the side, but we want to cut it really, really in the middle. Anyway, I just illustrate to you how we do it, but I think this is just showing that where you put the probe towards the right shoulder, and it will appear like this with the left atrium, left ventricle, right, the left ventricle outflow tract, the aorta, and the right ventricle on the other side. It will appear like this, and then you turn it 90 degrees towards the left shoulder, you appear like a donut feature like this, which is a left ventricle in short axis, and the right ventricle, the short axis. And yep, and when you put at the apex, it depends on where you cut. Yeah. So if you actually tilt it really, really upwards, you will have this like Mercedes-Benz signs, which actually means that's the aorta valve, aortic valve. But when you tilt it a bit lower, you will get the mitral valve. When you tilt it really bit lower, you get the papillary muscle level. And then when you really tilt it towards the apex, you will get the apex like that. So this is when you put your probe at the apex, just like putting stethoscope at the apex, you will find a structure like this that appear, and it means that this is the left atrium, left ventricle, right atrium, and right ventricle. The right ventricle is always smaller compared to the left ventricle. When it is same size or bigger, then we worry about emboli. So pulmonary emboli. So that's something that we can look for. So okay, so this is how it looks like. I think it. Okay, I can't play here, but I'll show the video in the next one. I think. Okay, this is the subcostal view that we had shown just now. Yeah. So it would appear slanted like this: left atrium, left ventricle, right atrium, and right ventricle. So yeah, you just put it under this. This is just like doing it for the fast ultrasound just now. So this is what a normal echo would look like on a parasternal long axis view, on the short axis view, on the apical, and the subcostal view. Yep. So they appear like this. So I will just quickly show. Okay, this is in pulmonary embolism. You will find that the right ventricle is dilated. This is the parasternal long axis view. This is in cardiac tamponade. You will see this in the subcostal view, whereby the right atrium and right ventricle collapse. Okay, this is how you do the echo. Basic echo.
For the heart, we use the echo probe. Now, echo probe has an arrow. Put the arrow over the left parasternal area around here, with the arrow pointing towards the right shoulder. And there you get a parasternal long axis view just like that. Yeah. So this is actually the left atrium, left ventricle, the aorta, the right ventricle. In fact, this is a descending aorta. Now, from here, you twist it 90 degrees. Now the arrow is pointing towards the left shoulder, and you could see like a donut, which is actually, this is a short axis view. And from here, you could tilt it downwards like that, and it will show you the apex. And you can tilt it upwards like that. And you could see this is like a small Mercedes-Benz sign here. This is actually the aorta, and here is actually your right ventricular outflow tract. Here, you move, same arrow that way, towards the apex area of your heart, just like when you listen to the stethoscope. Then you will get the apical four-chamber view, like that. This is the left atrium, left ventricle, right atrium, right ventricle. And if you twist it a little bit, you can tilt it. Then you could also get a five-chamber view if you tilt it a bit. So from here, you move to the subcostal area, the epigastrium. You try to make it flat. Then you could get the subcostal view of the heart. So there, left atrium, left ventricle, right atrium, right ventricle. So that is the echo.
Okay,
For the heart, we use.
we're done with echo, but we could, if we put our ultrasound at the subxiphoid area with the arrow pointing cranially in the longitudinal manner, we can see the inferior vena cava. And you can see if it is collapsed, that also shows that patient has is under volume, not enough fluids. But if patient has a dilated IVC, it can mean two things. Either patient has a lot of fluids already, or there's a heart failure. So these are some of the things that can help us. Yeah? And we could actually estimate the right atrial pressure, or the CVP, in terms of the size, and as it changes with the respiratory. If it is size is less than 1.5 cm total clap, then the right atrial pressure is between 0 to 5. So this correlates until, if it is big, more than 2.5 cm, less than 50% collapse with the inspiration, then the pressure would be, up to 20 centimeter water. So if it is higher, meaning that it's more than 20 centimeter water. This is the estimation by using the ultrasound. Now, under circulation, also we worry some of the patients may have abdominal aortic aneurysm. So if we put the probe, just like that, in transverse manner, we find like a round structure, and we measure outer to outer. Usually, the size should not be more than 3 centimeter. More than 3 centimeter is actually an aneurysm. And it's worrying for surgeons usually when the size is more than 5 centimeters. So you could see even clots sometimes inside the aorta. This is how you do for aorta.
For aorta, you can use either the abdominal probe or the echo probe. What you need to do is just place the probe directly transverse like that. And then when you do that, you'll see a large shadow here, which is your vertebra. And on that sits something which looks like a coin and is pulsatile. That's your aorta. And you run it down, and you can see there, as you run down, you can make it bigger if you want. You can see that when you get close to the umbilicus, it becomes 2. From 1 to 2. So that's aorta branching into the right and left common iliac arteries. And if you go back to aorta here, you could do it in a longitudinal manner like that. Yeah. And when you slant it towards the left, you can see all this thick wall, pulsatile, and that's actually your abdominal aorta, and you could run it downwards until it branches. So when you put it back here at the epigastrium, and then you slant it this way towards the right, then you will get the inferior vena cava. See, this is inferior vena cava, IVC draining into the right atrium.
Okay, so we can take a look at the deep vein thrombosis and pulmonary embolism as well. And for this, we just need to position patient like this and put the probe at the near the inguinal area. And when we put the probe, we can see there is actually at the common femoral artery, common femoral vein, you see like two coins here. And when you press, the vein will collapse. But if there is a thrombus, you cannot actually collapse the vein completely. So that can suggest pulmonary deep vein thrombosis.
For DVT, you use the high frequency probe. First, position the patient. So when the patient is like this, laterally rotate the limb, put the probe with the arrow towards this side, and scan over the inguinal area. And when you do that, you can see three coins, VAN, vein, artery, and actually this is nerve. So this is the vein, and you can see if there's thrombus inside, and you could press the probe. And if you can compress it completely, you're good. So from here, actually, if you tilt this upwards, you can see actually there is a branch to greater saphenous vein. And this looks like a Mickey Mouse standing ears. And you compress it, good. Then you go down, tilt this downwards. Then you can see two big ears like Mickey Mouse sleeping. And then you compress it. So actually that's between Mickey Mouse standing like this, and then when you go down with Mickey Mouse sleeping, those are the areas whereby you can compress because that's the most common site of the thrombus. Now you're done with this inguinal area, you move to the popliteal area, just put it there, the probe. And then when you put it there, you try to look for two coins against each other. And then you can see there's two coins, and then I compress it, and it actually get compressed completely. And this patient is cleared of thrombosis with the compression test. And you repeat the same test on the left side, and then you're done.
Okay, so that's for deep vein thrombosis. Okay, so this one I've already explained, that is like a vein. All right, so I mentioned to you about dilated right ventricle. So this can happen, this is short postal view in pulmonary embolism. So together with deep vein thrombosis, you find the vein could not be compressed, and you look at your echo, the right ventricle is dilated, then and clinically also patient may have symptoms of low oxygen saturation. So that points toward pulmonary embolism. So, okay, now when we do hypotensive resuscitation, we're trying to look whether there's a problem of circulation, whether it's a pump problem, you can look at the heart. If it is the pipe problem, you can look at the IVC, whether it's underfilled, or if there is a leakage problem, you can look at the aorta, or you could do FAST, whether there is any leakages, and also if there are also obstructive problem, for example, tension pneumothorax, you could look at the chest, or if there are hemothorax in trauma, looking at whether collection. So this is abdominal cardiac evaluation sonography in short or in short ACEs. Basically, it's a combination of what I taught you just now. You look at the heart, i.e. the pump function, you look at the aorta and IVC, i.e. the pipe problem, and you look for leakages, i.e. doing the FAST problem. So this is doing the ACEs. So you could also use your ultrasound during resuscitation, and you could see whether the heart is contracting or whether underfilled or there's cardiac tamponade, while during the 10 seconds in between the CPR, for example, and make the corrections. So this is published in paper called FEAR. So you could look for all the problem and correct the problem, because you could look at the heart, and usually also to decide whether to stop CPR, because usually if you see that there is a cardiac standstill, the survival rate is usually 0%. And also during the CPR, whether your compression is effective, you are really compressing the heart, you could put your probe on the aorta, just like when or the common femoral artery, just like looking for thrombus in DVT, but you're not looking at compressing the common femoral vein, but you're looking whether the common femoral artery is pulsatile or not with the CPR. If it moves with the CPR, meaning that you are doing the CPR correctly and the placement of your palm is correct. So now we look at the disability. So, you know, we can look at the eye, ultrasound of the eye, and we can look for globe rupture, foreign body, retinal detachment, or dilated optic nerve, which means there is a high intracranial pressure. This is what you get when you put the probe over the eye. This is the anterior chamber, posterior chamber, and this is the lens. And actually here, you could look at the optic nerve. Yep. So the optic nerve. And if you measure 3 centimeters behind the eye globe, and from side to side, outer to outer. So if the size is more than 6 millimeter, that means there's an increased intracranial pressure. Yeah. So there are multiple papers published. So this is where optic nerve sheath diameter is measured 3 millimeter behind the eye from side to side. And you can see this is an example that it is dilated when in a patient that has intracranial bleeding. So this is how you do it.
For the eye, I tend to make sure that the probe is clean. And in this one, we put the glove so that it's really clean. And I use water instead of gel because it's not alkali like the gel. I don't want the gel to go into the eyes. So what you do is just put some drops of water over the eye, and then place your probe over the eye. So from here, just put lightly over the eye, and then you could already see the eyeball. Yep. So that's the eyeball, and you could see this is the pupil, vitreous hemorrhage. If you can see something floating inside, and then you can sometimes try to look for retinal detachment. And if you look behind the eye, you will see that there is the optic nerve sheath. Yeah, behind the eye. So that is the, if you freeze it. So this is the optic nerve sheath, and it's slanted like that. Depends on where you place your probe, and you could measure it from side to side, 3 millimeters behind and side to side, whereby you look if it is dilated. And if the intracranial pressure dilates, then the size can be more than 6 millimeters. Usually the normal size is less than, well, some studies say 5.6, but less than 5.6 is considered normal. For the
Okay, how about ultrasound of the brain? So you could do it just like this, put the probe, and you could actually see the brain and the midline. And you could compare if there is a discrepancy large, that one side is larger than the other, that could point towards a midline shift. And apart from the optic nerve sheath diameter assessment. So this is like intracranial bleeding. Okay, this is an example.
Okay. For the brain, we can use the abdominal probe. Basically, we can place the probe along the line of base of skull, and actually it will pass through the sutures, brain sutures. So it's not very clear, but you can make out the skull and the ventricle. So you see, this is a ventricle. This is actually the midline, and then you can see the size, whether there is a discrepancy of size, especially when there is a midline shift with the brain injury. Okay.
Okay, so this is some of the diagnostic ultrasound. For example, you could look at cholelithiasis, gallbladder, cholecystitis. When you look at the gallbladder and the size is 4 millimeter and above. So this is how you do it.
Now for liver, it's if you look at the border of the subcostal, it goes like that. So you put your probe with the arrow here and run it just along the subcostal. That's how you look at liver. For example, here you start from here. So you just need to tilt up and down, and you can see the whole liver up there. Liver. Okay? And then you go down, and then you go up and down. You can see the whole liver, and you can look for abscess. And in this case, you can even find your bile. And this is important because sometimes you're looking for cholecystitis, you measure the wall. If it is more than 4, usually it is cholecystitis. So you could measure the size of the wall. Here it's just about 2.4 millimeters. And then you can go on to look at the whole liver, and like this, up and down, and then up and down, and you can look at the liver. So that's liver as well as the bile. Okay, now for liver.
Okay. So how about kidney? So you're concerned to look for renal calculi and hydronephrosis, for example. Yep, this is an example of renal calculi with a shadow. And to look for kidney.
It's just like doing fast, but we are looking at the kidney. So probe with the arrow this side slanted and the subcostal, just like when you're doing fast. Okay, so you try to find your kidney, and then there's the kidney, and focus on that. So from there, you can see if there are any calculi or any obstruction, hydronephrosis. Yeah? So just like that, you can look at the kidney by tilting it to every part, up and down. And we can also look at the transverse by turning it 90 degrees. And we can get the kidney in transverse appearance. Put it on the longitudinal view first. Okay, like that, and then turn it to 90 degrees. Then you can see the kidney in transverse form, and you can tilt it up and down. You can also look at the kidney in that manner. And the same on the left side, just like when you're doing fast. So and you can try to look whether there is any calculi with shadow forming behind. Tilt it up and down on the longitudinal axis, and then you can turn it 90 degrees, and then again tilt it up and down. So that's a short axis transverse view of the kidney. Okay,
Okay, so how about appendix? You could also look for appendix. It's a bit tricky looking for appendix, but it is not far from right common iliac artery and psoas, and towards it's towards the lateral, towards the ilium. Yeah. Okay, so this is an example how we're looking for
appendicitis. You can use a high frequency probe basically, you can give the probe to the patient and for patient to put at the area where it's most painful. But usually it's near the McBurney point. If you put your probe, actually you try to, it's near the right common iliac. You see the pulsatile artery, it's around that area. If I to increase the depth a bit, so it's between the peritoneum, around and also the muscle below. So it's around this area. So you need to look for a blind cylindrical structure which is not compressible. So that's probably it. It's not compressible. Yeah, and then if it is inflamed, the size will be more than 7 millimeters or more, and it's painful. Okay,
Okay, so the rest are something like pregnancy, whereby you look at the uterus is empty and you would be worried about ectopic pregnancy or molar pregnancy that appears like this. So basically this is a pelvic ultrasound. Musculoskeletal, you could put it over the skin. If there is a fluid collection, it will appear like cobblestone. You can also look for abscess as well that will appear more hypoechoic. Yep. So you could use this for procedural guidance and therapy, for cannulation, for vaginal block, for thoracocentesis, for pericardiocentesis. So, and even like this boy, to locate a glass, the foreign body. So you cannot do this with the X-ray, even CT scan. It's not good to detect glasses, but with ultrasound, you could locate it and determine the depth, the location, and actually how deep to cut through and mark the area and help the orthopedic surgeon to do it. So these are just some limitations. It depends very much on the operator. So I'm doing something impossible here of head to toe ultrasound, but in a nutshell, this is how you do it. And just to conclude, that ultrasound is the third eye. It provides you the vision of the structure of the problem to correct the problem accurately. It decreases the diagnostic time, and in some places you do not have access to CT scan and all, and ultrasound can actually help us to narrow down the diagnosis, or even better than CT scan at some point of time. And this is a time that we are now that we're moving into the age of visual medicine. With that, I thank you. So kembali ya kepada pengacara, saya stop the presentation ya. Okay. Maaf mengambil masa yang lama, but this is equivalent to like, I don't know, 3 days of workshop.
Okay, thank you very much, Datuk, for giving us such informative and interesting presentation. Okay, now, ladies and gentlemen, come to the question and answer session. I'd like to have question from the participants. Please use the raise hand and feature in Zoom, then unmute your microphone and camera, and then please state your name, you can type your question in the chat box, and I'm going to read them for you. Datuk, kita untuk pertama mungkin kita dari ruang chat ada pertanyaan from Dr. Ken. Good morning, sir. Can we look perforation of gaster with ultrasound?
Okay, so the question is that can we look at the perforation of the gaster? So there is a way. Usually we can put the probe at the just the way we look at the liver, and we look at the most sensitive part, usually near the left liver lobe, whereby the appearance is quite somewhat like the the A line when you scan the lung, and you see that there is an A line. So over that area, that is suggestive. That's number one. And number two is also the perforation can also cause the presentation of free fluids. So if you do fast at the same time looking for free fluids, coupled with this, then that points towards the perforation. Yeah, it's not depends on the size of the perforation. So it may or you may or may not get it. You still need to do more clinical assessment, and ultrasound is just supportive. Yes, that's my answer.
Oke, Dr. Ken. Dr. Ken, gimana? Dr. Ken masih online? Was
Mungkin lanjut aja.
Lanjut aja ya. Next. Good morning, sir. In LUS, we know that there is 20-point, 8-point, and 4-point protocols, with protocol that usually used in critical care or emergency setting.
Yeah. You can do 6 views, 4 views, 6 views, 12 views. But if you do more views, it will increase your sensitivity because you are assessing at more areas. But mostly when you do for 4 views, you would get the answer to your problem that you're looking for in most cases. And many times, especially in critical care situation, you have difficulty to put your probe on the posterior part behind the patient, because patient is intubated lying on the bed. So that may be a bit difficult. But the 4, personally, I do 4 because it's practical and I don't have much time. And those are enough to answer my clinical questions for the patient. That's my answer.
Okay, thank you. Yang raise hand ada yang online langsung ingin bertanya, dipersilakan ya, raise hand, open your video. Pertanyaan ketiga, dokter, is there any difference in from Dr. Doni Fajri? Is there any difference in IVC diameter patient with ventilator or normal room air? Doc?
Okay, let me read the question. I would
Yes.
like to ask, is there any difference in IVC diameter with ventilator or normal? Yes, the answer is yes. Usually for patient who is breathing spontaneously, we look at the collapsibility of the IVC. But for patients on ventilator, because ventilator is a positive pressure mechanism, so we don't look at the collapsibility. Instead, we look at the distensibility. So with a patient inspiration, we look at the distension. If the distension is usually more than 12 to 18%, some people use 12, some people use 18%. That is equivalent for someone on spontaneous respiration that we look at the 50% collapsibility. That's my answer.
Okay. Next question. We have 2 questions. The first is it possible for us to see cardiac emboli condition from ultrasound sonography after patient already to CPR because having cardiac arrest condition, doctor?
So is it possible to see cardiac emboli from ultrasound after patient already done CPR? After patient done CPR, after CPR, whether we can
After
see
CPR.
cardiac emboli. Depends if the thrombus is big and you could see, sometimes you could see blood clot also in cardiac arrest, but it's quite rare. but it can you can see that you can look at ventricular rupture as well. You can see areas whereby, for example, in the formation of clot in the ventricle, that's possible. So after the CPR, yeah, it is possible. Sometimes you could see it. Number two, how to differentiate between enough fluid with overload fluid.
Overload.
IVC image, because both UV image
Will be no collapse.
enough with overload. Okay, you have to see, you have multiple ways to confirm. When you look at the IVC alone, at a normal IVC can mean enough fluid. But when you want to answer whether it's actually overload, you look at other things. For example, you could put your probe on the lung and look for the B lines. So if you start to see the B lines and you look at the IVC, it is normal or big. And also when you look at the echo, the heart, that you see that the chambers are actually really big or not enough, or so all this you can plus the feature on the lung, you can plus the feature on the echo, then you could compare it with the IVC. Because sometimes when you look at the IVC, which is big or normal, but the heart function is not good, it still could mean that it is not because there's enough fluid, but because of the pump problem. So what I'm saying is that when you interpret the image, it's not just by one thing that you see. You have to actually look at other things that could cause that to appear. For you to have just enough fluid is actually, there are other parameters to look at. For example, nowadays, passive leg raise test that you could do, for which you could actually look at some of the parameters, what we call the VTI of the patient, whether there is improvement when you lift the leg up. If there is an improvement of more than 10%, then the patient can still take fluid, things like that.
Okay.
You have to look at the multiple parameters.
Okay.
From the ultrasound lecture, I've explained that you could actually look at multiple ways.
Okay, Datuk. Once more question in chat room. Assalamualaikum, sir. I would like to ask about the best technique for ultrasound guide intravenous access in hypovolemic patient, doctor. Best technique for USG guide intravenous IV. Yeah,
sometimes it can be difficult, especially for someone who is really, really severely dehydrated, because all the veins have collapsed. You could try, you could target the bigger veins, for example, the common femoral vein, but that too can be difficult when patient is really, really severely dehydrated. So for such patient, sometimes you have no choice but to give fluid by intraosseous needle first, and then once the tank has been filled up better, then the pipes will appear, making it easier for you to cannulate. But there are other techniques. For example, like if you want to put the central line or internal jugular vein, that you could actually do a Trendelenburg position for the patient, so that whatever fluid in the tank would sort of accumulate and make the vein bigger and easier for you to cannulate. And with the ultrasound, you could get that better. Yeah.
Okay. Okay. The next question from Dr. Awanda Herman. Good morning, Doctor, how do we know if there is retroperitoneal bleeding in cases such as kidney trauma with ultrasound?
Yeah, retroperitoneal is quite hard for ultrasound, using the ultrasound. A CT scan would actually show it better. There is at the best psoas abscess you could see, but for retroperitoneal is quite difficult. You may miss it with the ultrasound alone. So I wouldn't recommend ultrasound as the means to look at the retroperitoneal hematoma. You need CT scan.
Sorry. Okay, thank you, doctor. Oh yeah. Good morning, doctor. I would like to ask question: is there any tips and tricks that can be used for beginner to heart echocardiography in critical care? Tip and tricks
Yeah.
that can be used for beginner, doc.
Yeah, I think you should start with something simple. But I think a lot of people they don't understand what they're doing with the echo, because if you look at it, when you do echo, the pointer of the ultrasound, it's the other way around. It's not the same with the rest. On all other modes of abdominal ultrasound, or when you do the ultrasound, the pointer is always on the screen left. But when you do echo, the pointer is on the screen's right. Do you notice that? And actually, whatever you see, the image is like mirror image. It's like the other way around. Actually, why we do it? Because cardiologists did it that way. And I don't know why. Maybe just to make you all feel difficult, and therefore, only they know how to do it. No cardiologists here, right? So, but anyway, I think what you need to know is, like, for example, this bottle, you can see, right? The heart is like this, right? And when you do an echo, you do like this. It's a parasternal view. Remember that the pointer towards the right shoulder. Basically, what you're doing, you're just cutting through the heart in the longitudinal manner. So you will see the apex, and then you see the base. So this is on the screen. It would appear like cutting this thing. If I use a banana, this is a banana. And when you do like this, you're cutting it in short like this. When you do like this, you are cutting it through the apex. So when we understand that we do that, that we are looking at the heart, it's like cutting a banana. Yeah, and in that sense, that it makes more sense. I think it's easier when things make sense. So for you to start, it's like start with basic echo and try to make sense what you're doing. Yeah.
Okay. Dokter Novita, sepertinya kita harus workshop nih, Dokter Novita, seperti ini secara langsung.
Yeah, this is the beginning for next. We invite Dr. Alzamani to come to Pekanbaru, give us workshop.
Okay, doctor. Next question. Good morning, sir. Can we use ultrasound looking for cerebral hemorrhage or any other abnormality in brain, doc?
Ultrasound for the brain, there is a role to look at the flow in, for example, in aneurysm, also in assessing brain for in brain death, for example. There are multiple other things that can be used, but not to locate the hemorrhage other than the midline shift. So for the rest, looking at the activity, there is more advanced ultrasound that can be done. Yeah.
Okay. Okay. I think the last question. Assalamualaikum, Dr. Alzamani. In your opinion and experience, how accurate is the ultrasound assessment when assessing the hemodynamic status after fluid resuscitation of the patient compared to invasive method? And please share your expertise.
Okay, thank you for the question. I think it is very useful because we are looking at the state of the pipe, at the state of the pump directly. And the lungs also, there are multiple ways that could assist us because ultrasound can immediately give us, we look at the cardiac output, right, for basic leg raise test. But the ultrasound can give us the VTI, which is very easy to get. And we could compare that with a passive leg raise test and making it more accurate. And on top of that, it could show us other things like the state of the pump when we are deciding on the fluid and the state of the tank, whether it is enough or patient can actually, we can give some more. And also we could check whether after giving, because the invasive technique, it's first of all, it's invasive. Number two, is expensive. But there are limitations in terms of looking at other things. Invasive technique doesn't show us the B lines, for example, for someone who has a fluid overload. But ultrasound can, and it's cheap, it's not invasive. So to answer the question, I think it's very, very practical and much easier compared to invasive techniques and cheaper. So you could use the combined recommendation safe ways like PLR to do that with ultrasound to get the VTI, which is actually a surrogate for stroke volume and cardiac output. So I would advocate the use of ultrasound.
Okay. Any question? Oh, ada pertanyaan lagi, dokter. Good morning, Dr. Alzamani. Can you tell us more detail about head US in adult patient and its for pitfalls? Thank you. Ultrasound, head ultrasound.
Yeah, here ultrasound is through the openings of the sutures that is still there. Then it gives us some pictures of the brain, like I said just now, looking at the brain, looking at the midline shift and the flow that can suggest some of the brain condition. So that, and as well as the brain activity for brain death. And on top of that, the eye, the online, the optic nerve shift diameter also is correlating with the intracranial pressure. So these are some of the uses of the head ultrasound for adults. For pediatrics, there are also more usages because there is a opening bigger fontanelle that is still in existence. Probably for pediatric population, you may be able to look at hemorrhages as well.
Oke, saya rasa sudah begitu banyak pertanyaan, sepertinya sudah cukup ya. Kita, alright, then Datuk, thank you for the answer, the question. Ladies and gentlemen, we finally come to the end of the panel session. Before I close this panel, I would like to take the conclusion from what the speaker has presented. Head to toe basic ultrasonography is widely used by intensivists managing critically ill patients to accurately and rapidly assess different clinical scenarios. Basic ultrasonographic scale are routinely used to supplement physical examination of critically ill patient to determine the etiology of critical illness and to guide subsequent therapy. We could do cervical ultrasonography for airway, lung ultrasonography for breathing, echocardiography, vascular ultrasonography, abdominal ultrasonography, soft tissue ultrasonography for circulation, cranial ultrasonography for disability. For anesthesiology, ultrasound is so important and useful as a guide for block analgesia or anesthesia. And for other clinician, head-to-toe ultrasonography is also useful in determining the diagnosis and initial management of patient under certain condition. I like to thank the speaker for the informative and interesting presentation and all the participants for the very active participant. Finally, please give the applause for the speaker and for you all. Thank you, Dokter. Karena di awal saya membuka dengan pantun, maka saya akan tutup juga dengan pantun, Datuk. Jalan-jalan ke kota Mekah, ingin sembahyang berlama-lama. Semoga kegiatan Unlimited Expert ini membawa berkah, membawa rahmat untuk bersama. Bunga mekar di perbukitan, sawah luas di pedesaan. Terima kasih untuk perhatian, mohon maaf untuk kesalahan. I am Diana, the moderator of today. Mohon pamit undur. Wabillahi taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Foto bersama. Kembali ke MC. Foto bersama dulu.
Oh ya,
Belum mulai.
Dokter Diana mungkin ya. Baik dokter. Nah, kita mungkin silakan kepada semua partisipan, all of the participants open the camera. Kita foto bersama ya, karena ini momen yang sangat penting buat kita, dimana ini bahannya yang sangat bagus untuk dipresentasikan dan memudahkan kita untuk dalam praktek kita sehari-hari. Ya, apakah sudah dibuka semua kameranya untuk semua partisipan? Ya, ya kita instruksikan ya untuk yang pertama, ya. Kita mulai 1, 2, 3. Ya. Kemudian ya, Andre belum. Nusi. Ya. Kemudian 1, 2, 3. Ya. Ya. Satu kali lagi ya. 1, 2, 3. Iya. Terima kasih banyak kepada para peserta, dan kami sangat berterima kasih sekali kepada Datuk Dr. Alzamani Mohammad Idrose yang sudah menyampaikan sangat rinci dan sangat lengkap tentang penggunaan USG pada sembesan emergensi, dan itu sangat memudahkan kita dalam tindakan medis sehari-hari. Ini adalah kali kedua Datuk Muhammad Idrose untuk menyampaikan presentasinya dalam acara rinestesia. Mudah-mudahan ini tetap berlanjut, Datuk. Kami sangat berharap ilmu-ilmu Datuk untuk selanjutnya. Dan terima kasih kepada Dr. Diana Maskur, spesialis anestesi, yang sudah bersedia menjadi moderator. Baik, kita tutup acara ini. Ya. Mohon maaf Bila ada kekurangan dalam penyampaian, saya sebagai MC mohon maaf juga, dan terima kasih kepada semua panitia anestesia yang sudah menghadirkan dan memberikan materi yang sangat menarik. Terima kasih pada yang tetap membimbing PPDS Anestesi. Nah, mudah-mudahan untuk kegiatan berikutnya kita akan hadirkan info-info yang menarik kembali. Demikian kita tutup dengan bacaan hamdalah. Alhamdulillahirabbil alamin. Mohon maaf atas semua kesalahan. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam warahmatullahi wabarakatuh.
Bunga selasih pokok kayu. Terima kasih. Thank you.
Terima kasih Datuk. Sampai
Oke.
bertemu kembali.
Cakep gitu kan. Cakep.
Terima kasih Datuk.
Oke.
Ini introduction ini.
Introduction.
Habis ini pasti harus didatangkan untuk kasih
Workshop ya, Dr.
Kuliah.
Novita.
kuliah
Pengantar ya, Dok?
kuliah umum dan tempat ini baru pengantar introduction, pengantar dan workshop. Kita jemput Dr. Alzamani.
Harus diaplikasikan, Dokter.
Ya.
Terima kasih.
Alzamani
Dok.
masih gabung?
Sudah keluar sepertinya, Dokter.
Keluar ya.
Ya, Dok.
Oke. Ya, izin left.
Ya.
Terima kasih Dokter Novita.
Terima
Ya.
kasih.
Terima kasih Dokter Diana.
Sama-sama Dr. Citra.
Terima kasih
Terima
Dr.
kasih
Diana.
kepada semua peserta.
Ini udah goyang-goyang. Terima kasih Dr. Diana. Citra. Terima kasih Citra.
Terima kasih Dokter.